Dear friends, my message is very short and very simple. I just want to say that we displace the submacular hemorrhage due to AMD or other conditions with pure injection of C3F8 without any additional use of TPA or something like that. We used it in 11 eyes of 11 patients 12 times. All of them but one suffered from AMD, and we always apply 0.3 cubic centimeters of C3F8. If the patient tells us that he lost light perception, then we perform paracentesis, right? And then the patient follows down gaze position for several days. And usually the patient continues with anti-VEGF. So this is the first case, improvement from 0.1 to 0.9. Second case from 0.2 to 0.6. From 0.01 to 0.2. But another patient from 0.3 improved to 0.6, but the photo is missing. Then the patient had recurrence. We re-injected and improved to 0.5. This patient did have submacular bleeding caused by my assistant's periretinal membrane peeling, very strange condition, and he ended up with 0.1 vision only and atrophy of the ellipsoid, which is surprising, maybe caused by the toxic effect of blood. This patient from 0.5 improved to 0.15. From 0.15 later had a recurrence of large hemorrhage and ended up with fibrosis, so the treatment was not repeated. This patient had pigment epithelium rupture, so ended up with 0.05 vision. This patient had juxtapupillar CNV, so after the injection of gas, he was treated with direct laser and ended up with vision 1. And this patient, again with large submacular bleeding, ended up with 0.2 vision. Later, he developed a fibrous scar but still kept his vision 0.2. This patient improved a lot from 0.1 to 0.4, but later developed geographic atrophy and ended up with 0.16. And here we wanted to save or to salvage just some paracentral vision, so we applied the injection as well, and the vision stabilized at least. So you can see that all the columns which are above have improvement, quite a huge improvement in several cases, and some patients did not change, the last one, and this patient worsened due to geographic atrophy or fibrosis. And the mean visual acuity, if we can speak about something like statistics, improved from 0.2 to 0.4, and the mean follow-up was reliable. I would say that the functional result was not influenced in this group of patients. It was not influenced by the duration of hemorrhage, rather by etiopathogenesis. Of course, the patients with RP rupture or large fibrosis or geographic atrophy have poorer prognosis. We did not have any complications of the gas injection, and as I said, the patients who referred that they don't have light perception. And in these patients, we always check up the perfusion of the optic disc. And if it is necessary, we perform the paracentesis. So I want to say that submacular hemorrhage can easily be treated using pure C3F8 without the adjunct of TPA. Thank you.
Thank you so much. Any question from the audience? Please. I also have many questions.
Thank you, Ivan. Very interesting. I mean, my question is, what is the extent of the hemorrhage which you apply this technique? Is it a massive hemorrhage involving including the arcades, or is it smaller? What is the extent of the hemorrhage which would respond?
We calculated the area of the hemorrhage. Should we go back? I would classify it as a medium size submacular hemorrhage. I would not apply it in those cases of hemorrhagic detachment of the whole posterior pole going above the arcades, for instance. If this responds to your question.
I also have some questions. The first is how many days of face down position is just about usually? How many
We
days?
usually ask, these patients are very often they are old, and we cannot ask them to lay on their front and during the day and during the night. So we ask them, please follow the gaze down as much as you can, because this
And
rises.
for how many days?
At least 1 week, if this is
week.
possible.
So-
C3F8 reabsorption takes about 3 weeks or 1 month. So I don't think that within the last 2 weeks the tamponade effect or the pushing effect makes any difference. So I think the first days, first 5 or 7 days are the most important, but that's my personal feeling.
Sure. So why do you see 3F8? It is such a long time.
Because of the bubble we want to get as large as bubble as we can, and with SF6 without vitrectomy we cannot make a large bubble.
And with the C3F8 you make a larger bubble?
Sure. If we make 0.3 millimeters cubic
But
centimeter,
it expands, that's what you mean?
usually expansion.
It expands after the injection, that's why. Sorry. It expands. You inject pure C3F8,
Right.
so you wait an expansion.
Pure 0.3
And you
cubic
wait for the
centimeters
expansion.
C3F8, it expands up to one cubic centimeter.
Please.
Ivan Tane from Bulgaria. Thank you very much for the presentation. I would like to ask you, do you consider if the posture is not possible, just inject TPA under the retina? Because the posture is different. If you inject the gas, you should follow certain posture. And for some people, elderly, it's very difficult to keep the posture like this, like a supine position. If you inject directly 41 gauge camera, the TPA, plasmid gain activator, so it will be different posture, much more easier to be kept.
That could be possible, but what I was trying to show is that it can be done without the TPA, and I was showing that most of the patients had some benefit. And getting the TPA is not that easy for somebody, so that was also my message.
Yeah.
Hello, I want to ask you, did you see the patients the day after? How long it takes for the gas to move the clot or the hemorrhage? And the other question is, did you compare with the TPI hemorrhages,
No.
the results, the visual acuity results?
First, I have to answer the second question. We did not use the TPA. I have to confess that I have never used the TPA for logistic reasons. And your question, how long does it take for the displacement of the blood? Just several days. Within 1 week, usually the blood is gone from the fovea.
I ask if you compare TPR results with gas results. Your results with the other patients treated with TPI and gas.
Or with other studies?
Yes.
No, this was not the subject of this presentation.
Okay, thank you.
Thank you.
Hi, Ivan. Nice talk. So I want you precision about the action of your procedure. Is it by modifying the blood flow, or is it also a healing process induced by the resorption of the hemorrhage?
Thank you very much, Richard. I could expect a question like that from you. Do we have time to go into details? To be honest, I usually do not believe that much in the physical effect of the gas bubble pushing. For instance, in the cases of macular hole, I don't think that the edges of the macular hole are pushed against the eyeball by the bubble, because the physical buoyance of the bubble is minimal. So, in fact, I am surprised that this method works in this patient of submacular hemorrhage. So, if you are trying to indicate that there could be some other mechanism of the blood displacement, other from physical power pushing the blood out from the fovea, I would welcome that view and the explanation.
Thank you.
Giacomo, can I make a comment to that? Petersen from Göttingen is a physicist, and he once pointed out that in an enclosed space, the pressure in every point is the same. So if you look at the top of the bubble and the inside of the retina, it's the same pressure. So physically, with what you're saying, the bubble cannot displace the blood. So I agree with you. I'd like an explanation how this works.
I'm very grateful for your
sorry.
comment. Thanks.
We have to move on. I'm sorry.